Okay, so just a bit of a precursor, just a bit of a difference in pharm this semester and last semester. Last semester, your entire pharm would have been basically like antibiotics, and it's a lot of like mnemonics and just trying your best to remember. But from now on in med in general, pharmacology, the focus of study should a lot be more on what the drug is doing, because that will basically tell you everything. If you know what the drug is doing, you can work out the side effects, indications, contraindications, and everything else. And yeah, when you do cardio, it's the same thing. The easiest way to do the questions in cardio, they do have a big focus on adverse effects and indications and all that. So it's quite important to know exactly what you're doing rather than just remember a drug mechanism. Okay. And then how to understand pharm in general is just remember that there's no one size fits all, but try and understand it. Flashcards are probably the best thing you can do for pharm, because as much as you can understand it, there is still memorization. So I write flashcards, but I know people are very into Quizlet and Anki. Questions are the same thing, okay? And then what to know about each drug. You should basically know how it works when we use it, some drugs, specifically when we don't use it, the side effects, and then sometimes the drug has, some fun facts. Sometimes it's important to know. Okay, resources. This is for pharm and also for what I use in general. So there's a website called Handwritten Tutorials, which is amazing. They don't have so many videos, but it's a really good level. Khan Academy, I'm in love with. I don't know if any of you guys listen to podcasts, but Humorous Hacks is an amazing podcast because it was made by Monash students and they did it while they were in medical school. So they have, it's very much at the level of medical school, and it is a little bit more clinical. So it also takes what you learn, if you do it on a topic you're doing now. So I know they have 1 or 2 or 3 on cardio, and it makes it very clinical, so it feels applicable. And you guys know about the Numis Drive, and study groups are also a great thing if you can actually study with the group. Doesn't work for everyone, only works for me sometimes. Okay, let's get into some pharmacology. Okay, so just a few small definitions. There's the minimum effective concentration, so that's what concentration in the plasma the drug starts working. Then there's the minimum toxic concentration, which is at what point you've got too much and you're actually having, adverse effects. I think they explain that the toxic concentration is when the adverse effects override the therapeutic effects. Because obviously, even at a regular effective dose, there might be some side effects, but we won't call that toxic if it's not bad enough. The therapeutic window is between these two measurements. So that's, the plasma concentration that is just considered good. And then duration of therapy is between onset and offset. So that's basically when it's in till when it's out of the therapeutic window for whatever, whether it's above or below. Okay. Absorption. So the bioavailability is the fraction of the administered dose that reaches the bloodstream unchanged, which can vary quite a lot with different forms of administration. So obviously IV will be 100%, and then, because that's straight into the bloodstream. And then as you get further and further away from the bloodstream, sort of in inverted commas, the bioavailability will go down. So with the lowest obviously being oral, because it has to get through the gastrointestinal system and be absorbed. So some things to think about in oral administration, because these will inform whether or not you actually give a drug orally. So that could be gastric content or gastric motility. So, if the patient's got diarrhea, that it might not actually be useful, or if they're throwing up or whatever. The blood flow to the GI tract and acid interactions, because the gastrointestinal system is quite acidic at times, and at other times it actually gets a bit more basic. So you've got to be aware of that. Lipophilicity. So if it's lipophilic, it will go straight through the wall and it's absorbed much faster. Be aware that many drugs must be activated in the liver because only the metabolite is active. So the metabolite is what the body has done to the drug. It's the product after the body processes it, So many drugs must be activated first, so you might have to do it orally to get it to the liver first. And then always be aware of this first pass effect, which is basically how much of the drug is inactivated in the liver before reaching systemic circulation, because anything that's absorbed through the gastrointestinal system basically has to go through the liver, through the veins to the liver before it can enter the rest of the body. So if it's been somewhat processed, it's not going to be as good. And then routes of administration in order of speed. So this is from fastest to slowest. So there's inhalation, sublingual, IV, intramuscular injections, subcut, and oral. People tend to not know that inhalation is really fast, but you just have to think of it as that the only drug that's going to have a therapeutic effect is what is in the arteries, because that's what gets sent out to the body, and that's what enters the tissue. So if you inhale it and it enters the lungs, that it's basically entering the blood as it's being oxygenated. Let's compare that to IV, where it's entering venous blood and it has to get back to the heart, then to the lungs, then to the body. Not that important or high yield, but I just think it's interesting and people don't know it. Okay, volume distribution. I don't know about what happened this year, but I know last year people were very confused by it. And I will go more into it, but the concept of the volume distribution is that we're testing how much of the drug remains in the bloodstream or the plasma and how much goes out to the tissues. So a higher volume distribution means that more volume is out into the tissues. So things that impact distribution. So if there's binding to plasma protein, it goes higher. Hold on. I think I've gotten this wrong. Hold on. I think I've made a mistake.
I think it should be the other way around.
Yeah, it should be the other way around. I'll fix it in the post slides. But basically, if it's plasma protein, it's lower because there's more in the plasma. If it's binding to tissue, it's higher. Lipid solubility, that one's correct. It should be higher. So it's just those first two. I think I've made a mistake. Those should be higher. And basically, anything that gets it further into the tissues, it'll be higher. Yeah. Anything that keeps it in the plasma should be lower. I apologize. I will change that. But just remember, the more in the tissues, the higher the volume distribution. Okay. And then I did a little bit of the maths of how it works. Some people's brains like this, some won't. If you don't, then ignore it. So the volume distribution is calculated by the drug in the body divided by the plasma concentration, which you can then put the plasma in concentration as the amount in the plasma over the volume. And then when you make that into a neater fraction, you can cancel out the units. So you end up with the dose in the body divided by the dose in the plasma times the volume. When we do concentration, though, the volume is 1. So you're left with the volume distribution is the amount of drug in the body divided by the amount of drug in 1 liter of plasma. So basically, the more you have in the plasma, the bigger the denominator and the lower the volume distribution. Again, that might not make sense to everyone, but if people, the more mathsy people might learn from it. And just remember, the volume distribution, the big thing that we use it for is this thing called a loading dose, because we call the active drug what is free in the plasma. So the more that leaves the tissues, the less you have. The more that leaves to the tissues, the less you have in the plasma. So we can give this loading dose and just fill up the tissue and then go from there. So examples of volume distribution. So things which are intravascular, so they specifically stay in the bloodstream, will have the lowest because they just don't leave the bloodstream. Interstitial fluid will be next lowest because they don't enter tissues. They only leave the bloodstream and they sit in the fluids around. Then intracellular means they enter cells, so that can be even higher because now there's all this intracellular space which can be filled with drug. And then tissue binding will obviously be the highest because they're bound all over the body. And then there's different features which basically they have to do with how much a particular substance will, diffuse through cell walls or diffuse between cells, but they're fairly straightforward. Okay, a steady state is basically because the body gets rid of sort of half of the drug in a certain amount of time, being the half-life. The body has this sort of, if you're giving dose at a specific time every day, you end up with this sort of oscillation. And the steady state is what is at some point, you'll basically be oscillating between 1 and 2 units every day, because you'll get to 1 unit and then you'll take another dose and it'll bring it back up to 2. For example, when we look at antibiotics, a lot of the half-life is about 8 hours, which is why we're giving it every 6 to 8 hours for anyone who's ever had to take antibiotics. And the sort of thing that they ask a lot about is how many half-lives to achieve steady state, and it's about 4 to 5. I think the answers usually tend to say about 4.5. Because you can see you never reach that perfect steady state, but it's when it's about, oscillating between 1 and 2. Okay, metabolism and elimination. So liver clearance is basically the liver will, when things can't be eliminated by the kidneys, the liver will change it a little bit so that the kidneys can actually deal with it. So for example, if something's very lipophilic, what will happen is it will enter the tubules in the kidneys and it will just leave. It'll just diffuse out, and that is not what we want. So there's 2 types of reactions, and the names of them are arbitrary. It was just when they were discovered. So phase 1 reaction is catabolic. So that's where it will break it down a little bit. It will take off a chunk, and then it will be the drug will be more polar, and then the kidneys can deal with it. And phase 2 reactions are anabolic, which means building. So there's a few things that this accomplishes. It does it through something called conjugation, which is basically you'll take another molecule that's more polar and you'll just add it on to the drug or to the thing that's trying to be eliminated. And this will increase its size, so it's harder for it to enter the cell, and it's harder for it to do its job. It will make it more polar so the kidneys can deal with it, and it will make it inert pharmacologically, because it will very likely mess with its binding site and its tertiary structure and such. And then renal clearance. This did come up. I don't know if it came up in our exam, but it's filtration, which is the amount that just enters the kidneys when the blood enters, plus secretion, which is the amount that enters through the walls, minus reabsorption, which is the amount that leaves through the walls. And that will make your overall clearance rate. It's you just take all the things that can happen to make it enter or leave the kidney, and you work it out from there. And for any given drug, the clearance rate is constant for a given concentration. So obviously it could vary a little bit between people, but the point of saying that it's constant is that it's not a function of anything, it's just a number. And then first and zero order kinetics is about elimination. So first order is the one that we normally look at. That's the one where half-life is relevant. And that's where the amount of the drug will determine how fast it's eliminated. And yeah, so that's where half-life becomes relevant, because we measure it in terms of how long it takes for half to disappear. Whereas zero order is when all the enzymes that deal with the drug are in use. So it can only do a specific amount of drug per time. So the most famous example is alcohol. You can only do one standard drink per hour can be eliminated. There's no concept of a half-life. The more you drink, the longer it takes, for every unit that you drink. Okay, so this triangle is just a little bit, it's a bit of just a synthesis of a bunch of different things. I'll explain it. The post slides will have it in the notes, which is like the notes that I wrote to explain it now. And so you can look back at it, but it's honestly not that important if you have a pretty good understanding of what is volume distribution and what is clearance, and everything else is sort of just trying to make it pretty, but it's not really. Okay, so we'll start with clearance, which is the left part of the triangle in the middle there. So that's the amount of time, the amount of a drug cleared let's say in an hour for per plasma concentration. So it's the amount cleared per time divided by plasma concentration. And then the rate of elimination is the amount cleared per time. So if you think about it, if the clearance is the amount cleared per time divided by plasma concentration, I'm getting up to point, but I shouldn't be. If you start from the bottom and do plasma concentration times the clearance, you'll end up with the amount cleared per time, which is the rate of elimination. Volume distribution, we've basically explained how that works. What they've done on the triangle with the multiplication is just a small sort of manipulation of it, because we taught it as volume distribution is the amount in the body divided by the plasma concentration. So that's basically the same thing. And I would say ignore the K. It was never really taught, but if you want, we can explain it as the fraction of a substance removed per time. So when that's multiplied by the total amount of substance, you'll end up with the renal elimination, because we know what fraction of, so if there's 1 liter and we know that the fraction is 0.25, we know that 0.25 is being eliminated per unit of time. And now this relationship between volume distribution, clearance, and half-life, to the best of my knowledge, there's 0.693. It was determined by biochemists and physicists, and it's not really anything you have to know properly. I would say at best, just be able to recognize that equation and know what it is, and know that the number is 0.693, like upon seeing it. You don't really have to be able to recall the equation. I hope that all made sense, because this triangle is just an absolute mess. Okay, so when administering a drug orally, which of the following elements of a drug increases its ability to be absorbed in the gastrointestinal tract? So we have low molecular weight, ionic, lipophilic, and a long half-life. So the answers are, there's actually 2 answers. Low molecular weight means it's easy to pass through the gastrointestinal wall. The bigger it is, the harder it is to pass. Ionic usually takes longer because it can't pass straight through. And lipophilic, like I said, it can pass straight through. It's the opposite of ionic. And the longer half-life doesn't necessarily reflect absorption. It could be, it's lipophilic and then it gets stuck in the tissues and it has a longer half-life, but it could also just be it has a high affinity for plasma proteins, so it just takes ages to be eliminated. Yeah. Okay. So of a given drug, which of these properties would result in plasma sequestration, which basically just means being stuck in the plasma? I'm sure you were all sequesters at your interviews, so you know the word. So there's the high plasma protein binding, low bioavailability, high volume distribution, high lipophilicity, and rapid metabolism. So it is the high plasma protein binding, and I sort of explained that in the previous question. But just to flesh it out, the body can only eliminate free substances if it's bound to our own proteins. In a normally functioning body, it can't eliminate said substances. So anything that gets stuck to plasma proteins or that are bound quite tightly to it, they won't leave the bloodstream because they're stuck to the proteins, which can't leave the bloodstream, and they won't be eliminated. So they just sit in the plasma.
As a side effect, would you get low bioavailability as well? As an effect more than a cause for this?
Well, bioavailability is what ends up in the bloodstream. So it's still
with the unbound portion, because that's what's physiologically active.
Yeah, potentially you actually would end up with the low bioavailability. But the low bioavailability wouldn't cause it to be stuck in the plasma. Absolutely. Yeah, you are correct. Okay, so which of the following units measures the therapeutic properties of a drug in comparison to its toxic properties? And that is, so there's potency, volume distribution, minimum effective concentration, therapeutic index, and clearance rate. And it is the therapeutic index. So the therapeutic index is the concentration for toxicity divided by the concentration for therapeutic effect. And again, toxicity is determined by what we call too much toxicity, because most drugs have a little bit. So obviously, the bigger the number, the more drug you need for toxic properties to override anything. So you want a high therapeutic index, means it's a safer drug. The classic example is like penicillin has like a really high therapeutic index. Unless you're allergic to it, most people are really fine on it. Okay, so which of the following factors will determine the number of drug receptor complexes formed? So we have the efficacy of the drug, the receptor affinity for the drug, the therapeutic index for the drug, the half-life of the drug, and the rate of renal secretion. So it is the receptor affinity for the drug. And the reason it's not the efficacy of the drug is because the efficacy of the drug is how well it works, not how well it binds to receptors. So for example, if something's an antagonist, it should have a really good affinity for the receptor, but its efficacy should be very low because it should attach and not do anything. Yeah. And then the rest, just they don't have much to do with drug receptor complexes. Okay, moving on to the autonomic nervous system and the neuromuscular junction. So this is just a really good image that breaks down what the sympathetic and parasympathetic nervous system do. I think most people like to think of it in terms of the fight or flight response. So sympathetic, you just think about what you need to survive if you are in a life-threatening situation right now. And parasympathetic are the things you can do when you're a little bit safer, or what the body can do. So I've also just given it in terms of a list. So the mnemonic we were given in lectures was dumbbells with 2 B's. I don't know if it should be 2 S's, I don't know. So that goes to diarrhea, because gastric motility goes up a lot, urination, because body feels safe to deal with these things, eye contraction, because we don't need to see as much light if we're not terrified, bradycardia, because we don't need to increase, we can have a lower heart rate because we're not doing anything physically strenuous at that time. Bronchospasm just is because the lungs contract, because again, you don't need that big inhale. You can actually have smaller lungs. And if you have enough parasympathetic action, you'll get a bronchospasm. It should not be excitation of skeletal muscle, but that's wrong. It should be less excitation of skeletal muscle. Lacrimation, lethargy, sweating, and salivation. So lacrimation is tears. Lethargy is just being sort of tired and fatigued. Sweating and salivation. Again, these are all things to do with upkeep of the body in general, rather than being safe at this moment. Sympathetic nervous system are all about being safe in this moment. So fever, it just means your temperature increases, your basal metabolic rate increases. There's a lack of sweating because you're trying to conserve water. You get very flushed because you have your blood pressure increases. Your eyes dilate and more light. So more light can come in. Constipation because the stomach basically stops. Urinary retention, again, saving water. And then hypothermia in infants because they don't have good temperature regulation. So their temperature goes up and it gets a lot more intense. So this is actually kind of important to know. And once you do know it, it sort of sticks with you, different receptors and what they do. And just remember that the sympathetic nervous system uses alpha and beta receptors. The parasympathetic uses muscarinic receptors, and everything else is nicotinic receptors. So between, at the ganglia, it's nicotinic. At somatic skeletal muscles, it's nicotinic. The adrenal gland is nicotinic. Just remember that sympathetic is alpha and beta, which becomes relevant anyways. So you remember when you do cardio, because they do beta blockers and all that. And muscarinic is parasympathetic. And then there's like a few other details, like for example, the ganglia for the parasympathetic nervous system, it's more distal, but like that's not as important for now. Focus more on like what the receptors are and what the neurotransmitter is at these receptors. And basically everything is acetylcholine except the sympathetic nervous system, which has norepinephrine, or we can say noradrenaline, because people are more aware that adrenaline starts pumping when we're in fight or flight. And it's easier to remember that way, even though it is the American way. Okay, so this is just going through what the different receptors do. So we have 5 different muscarinic receptors that we know of. So M1 is the head, and it's all about eating. So salivation, gastric acid secretion, central nervous system. M2 is the heart and the smooth muscle. So it slows down the heart and it makes the heart less contractile. A smooth muscle also, depending on which smooth muscle it is, will show what's happening. And then M3 is the smooth muscle of the gastrointestinal system, the lungs, some vascular endothelial cells, which is basically the blood vessels, and exocrine glands, and M4 and M5 are the central nervous system. And we don't really know what it does, but we just know it's involved in a few central nervous system diseases like Alzheimer's, Parkinson's, depression, and schizophrenia. The way that I always remembered this was I just sort of went down the body. So M1, is the head and the face, which is sort of all about eating. M2 is at the chest, so it's the heart. M3 is the gastrointestinal systems and the more distal things like vasculature. And M4, M5, I was like, oh, we don't really know what it does, and we're thinking about it. So central nervous system. But yeah, that was how I could, that's what I did to learn it very quickly, because it's not so high yield. Sympathetic receptors, parts of this are quite important. So it broadly is alpha and beta. Then within that, it has subdivisions. There's even more subdivisions within that, but it is not in the scope of the course. So we have alpha 1, which works on vascular smooth muscle and urinary smooth muscle and the eye, and basically everything contracts. Alpha is contraction, at least alpha 1. Alpha 2 works at the presynaptic nerve terminal, right where the noradrenaline is going to be released, and its role is to stop that release and to stop alpha 1 from working. So it's sort of its own inhibition. And then beta 1 is the heart, the kidneys, and the eyes. It's super relevant for the heart. It increases contractility, it increases heart rate. And then when you do the RAS system, or if you have done the RAS system, it increases renin as well. Beta 2 is the bronchial smooth muscle, so that's relaxed bronchioles and vasculature. So yeah, it's also the vascular smooth muscle. So just remember, when it comes to vasculature, alpha is contraction and beta is relaxation, and that is how the body is able to contract and relax the vasculature to different places for fight or flight, because the muscle needs more blood, but the gastrointestinal system needs less. And B3 is adipose cell and smooth muscle, but that's sort of way less relevant to what we're doing. Okay, some things to note. Don't really think it's important, but it's come up in all of the resources I've seen. So alpha receptors, norepinephrine it binds more strongly than epinephrine, which is more strong than isoproterenol. And then for beta receptors, isoproterenol is stronger than epinephrine than norepinephrine. And generally, epinephrine binds more strongly to beta than alpha, but at high doses, it gets funky. And there's quite a lot of drugs like that where high doses, things just change. And then the way that the muscarinic 3 receptors promote relaxation of vascular smooth muscle is through nitrous oxide, which will again be relevant when you do cardio. Okay, some drugs that we need to know about. So adrenergic drugs, so that means things that have to do with the sympathetic nervous system. So that's beta agonists, so there's formoterol and salbutamol, so that leads to bronchodilation, and it's used in the treatment of asthma. It also increases cardiac contraction, but the examples I've given there are actually inhalation ones, so those are used in asthma. And then there's the opposite, which is a beta blocker, like metoprolol or atenolol, and that's the opposite of a beta agonist, so it's used in hypertension to lower the strength of heart contraction and slow the heart, that should say. And you don't give into an asthmatic just because if it's non-selective, you will close up their airways, and that's bad news. And even if it is selective, our drugs are far from perfect, and asthmatics will often report effects. So you just do not give beta blockers to an asthmatic unless, you know, there's other things going on. And then looking a bit at cholinergic transmission. Now, I'm just going to point out a few things on this image because there's a lot going on and not all of it is so important. But just know that there is when the acetylcholine gets released, it binds to nicotinic receptors. So we can sort of play with things there by blocking the receptors, or you can use an agonist for the receptors, make it stronger. Then acetylcholine is basically broken down by something called acetylcholine esterase. And so therefore, if we play with that as well, we can change the amount of acetylcholine in the synapse. For example, if we use an acetylcholine esterase inhibitor, like neostigmine, like it has on the image, you can actually increase the acetylcholine in the neuromuscular junction, and it will lead to more binding to the receptor. And also bear in mind, we can actually do something quite interesting. We can add a depolarizing blocking agent, which basically means it binds to the receptor, it activates the receptor, and then it just sits there and it keeps it open. And basically the postsynaptic, whatever's going on, the muscle or the nerve or whatever's going on, that will basically be stuck polarized and it can't start again. So that's another way of stopping it, by sort of making it work too much. So some drugs, and I apologize, there's just going to be a bunch of drugs, and just try and remember what they do, because that will help the most. But I at least remember for these ones, I did a lot of flashcards. So pyridostigmine is an anticholinesterase inhibitor. Now, when it says anticholinesterase, there's lots of names for this enzyme I found. So it can be cholinesterase or acetylcholinesterase or anticholinesterase. It's all the same thing. It's all breaking down acetylcholine. So this will increase neurotransmission because there's more acetylcholine in the synapse, and that can then bind to receptors. This will increase parasympathetic activity, specifically because it just keeps bumping into the muscarinic receptors, which can lead to things like exacerbation of COPD or asthma, because the parasympathetic nervous system is what leads to contraction of the lungs. It can lead to peptic ulcers, because what happens is the stomach, during the safe period, the rest and digest period, says, oh, now it's time to eat, and it just puts out a lot of acid, and then that can lead to problems. Now this comes up like over and over again, just as like a little side point for some reason, myasthenia gravis, but that's basically an autoimmune disease which attacks I think it attacks nicotinic receptors. So basically, by giving an anticholinesterase inhibitor, we're just putting more acetylcholine in the neuromuscular junction, and it can, and then they can bind to the receptor. It's also given for myasthenia gravis, often in conjunction with some sort of, steroid or some sort of immunomodulating drug. And then there's atropine. So that's a muscarinic antagonist. So that's stopping the parasympathetic nervous system. I just included this title, competitive muscarinic inverse agonist, because I thought that's just confusing. And if you see it anywhere, you'll now know it's an antagonist. So it leads to sympathetic activity. So the eyes dilate, they contract a lot, myidrasis or cycloplegia, which is, I can't even remember anymore, really don't even know, something to do with the eyes. And it's often used in eye exams. Myidrasis is eye dilation because the sympathetic nervous system is taking over, and it's used in eye exams because that way we can see more easily, because you have to be able to see through the pupils. And organophosphate poisoning we'll look at soon, but that blocks acetylcholinesterase, so that leads to too much acetylcholine, too much muscarinic activation. So if we have an antagonist, we can stop it. Cholinergic drugs, so there's bethanechol, which is a muscarinic agonist, so it's the opposite to atropine, so it leads to more activation, and it does, if you read what it's used for, it's just when we want more parasympathetic system going on. Botulinum toxin, again, it's one of those things that just like comes up and I don't know why, but it stops the release of acetylcholine. So it has quite a systemic effect because, like I said, acetylcholine does everything except the end point of the autonomic nervous system. So it's also in the middle of the autonomic nervous system at the ganglia. So it basically interrupts everything and you can die really quickly. So here's a case. So Alex, a gardener by profession, presents to the emergency department complaining that while working, he was suddenly unable to pick vegetables properly. He had an unsteady gait and his eyes were extremely contracted and were filled with tears. A co-worker who accompanied him mentioned that earlier that morning, he had mentioned his chest was feeling tight. So which system dominates this patient? I think it's fairly straightforward that it's the parasympathetic nervous system, lots of lacrimation, which are tears. His eyes are very contracted. His chest was tight. Classic signs of parasympathetic nervous system activation. So let's look at how this can occur. How can it be that your parasympathetic nervous system relatively suddenly starts going on too much? So you can either have something that inhibits the cholinesterase, so you have too much acetylcholine at the synapse or the neuromuscular junction. You have a muscarinic antagonist, which is forcing the parasympathetic nervous system to work harder, or an alpha and beta blockers, because what we see a lot of the time is that the two parts of the autonomic nervous system, they work sort of hand in hand. So if one goes down, the other goes up. So if you stop the sympathetic nervous system, parasympathetic goes up. So back to the case, I'm going to focus on some of the more important things to help us work out what's going on. He's a gardener by profession, and that his symptoms started earlier in the morning. To the best of our knowledge, he didn't have symptoms before, otherwise someone would have mentioned it. So just things to remember is that pesticides are cholinesterase inhibitors a lot of the time. So those are organophosphates. And they have a relatively quick onset, which is implying that it's not some sort of slow pathological thing like an autoimmune disease. This seems to imply a bit more that there's some sort of drug or something inside of this Alex character. Okay. So what intervention would you give Alex? So you can give him physostigmine, which is a cholinesterase inhibitor, propranolol, a beta blocker, noradrenaline, atropine, or bethanacol, sorry. And the answer is atropine, because it's a muscarinic receptor antagonist, and you can give it, and then once the drug is cleared from Alex, you don't have to give it again. Okay, a 66-year-old woman with a long history of smoking presents her doctor with complaints of shortness of breath and chronic coughing that has been present for about 2 years and has been worsening in frequency. The doctor decides to prescribe a bronchodilator agent that has minimal cardiac side effects, since the patient also has an extensive cardiac history. Which medication did the doctor likely prescribe? So we have a beta-2 agonist, an alpha-1 blocker, a muscarinic receptor blocker, a beta blocker, and atropine. And he gives the beta-2 agonist because at the end of the day, we can say that it might have an effect on the heart, but if the person can't breathe properly, this will start to justify using a selective thing. Also, when the heart starts working a little bit harder or less hard, it's usually more you have time to play with doses and medications as opposed to asthma, which tends to be quite acute, which is why this is slightly different to the rule we said earlier, which was don't give a beta blocker or a beta agonist when you're playing around, when there's other systems involved. Okay, in many emergency surgeries and traumas, local anesthetic is administered in conjunction with noradrenaline. So why is this done? So there's noradrenaline causes vasodilation in the muscles, promoting endorphin release, so there's less pain. Noradrenaline can be used to raise blood pressure and prevent fainting. Noradrenaline causes vasoconstriction, reducing bleeding to the area. Noradrenaline will delay stomach emptying, so there is more time for the surgery. Or noradrenaline reduces the pain associated with surgery. And the answer is it causes vasoconstriction. So basically, that has actually a double effect, one of which I've written, that it reduces the bleeding. It also keeps the drug in the area because these things tend to be carried in the blood. And if there's vasoconstriction, there's just less movement. Myasthenia gravis is an autoimmune disease which destroys nicotinic receptors. Which of the following would be an effective drug? So I'm just going to go for the answer here. There's pyridostigmine, which is in the long term. That's an acetylcholine acetylcholinesterase inhibitor. So that's, again, keep more acetylcholine because there's less receptors. That way they can hit the receptors more often. And then this is some extra information. Endrophonium is the same thing, but very short acting, and they just use it in diagnosis. Because if you give someone a quick dose of this and all of a sudden their symptoms stop, you know likely that what you're dealing with. Topical application of timolol, which is a beta blocker, to the eye would be expected to induce which of the following? So you have miosis, mydriasis, decreased formation of aqueous humor, and increased outflow of aqueous humor, and it's decreased formation of aqueous humor. Really small side point, but I thought if it's in a question, maybe someone will remember it and it will help them with a small side point. Okay, DMARDs. So these are disease-modifying anti-rheumatic drugs. So rheumatic means it's an immunological issue. And the goal of treatment is to decrease inflammation in any way. So we can reduce the number of white blood cells, reduce the targets, reduce migration, or reduce recruitment. And that's all looking at different parts of the white blood cell system. That is just what happens in arthritis, list of drugs. Let's get to the drugs. So methotrexate is a cancer drug used in very low doses. It's a folic acid analog that competitively inhibits dihydrofolate reductase, less DNA synthesis, and less white blood cells since they have major turnover. In small doses, there's an additional role of some immunosuppression that we don't understand. You definitely don't give it to someone who's pregnant because we know every person who wants to get pregnant should take folate. We're literally stopping folate, so you can sort of see why you won't want those together. And just remember that in low doses, it barely works like a cancer drug. My dad's a rheumatologist, and he gets very upset when people get scared of methotrexate because it's really fine, and GPs are scared of giving it. Leflunomide is an immunosuppressive drug which suppresses T-cell proliferation by reversibly inhibiting trihydroorotate dehydrogenase. That enzyme's way less important than knowing the dihydrofolate reductase inhibitor. For some reason, they ask questions on that one. It's used in rheumatoid arthritis, and it's hepatotoxic. There's azathioprine, which is another, I believe, cancer drug, and it puts itself into the nucleic acid and it stops purine synthesis, so it's called a purine analog. So same sort of concept, and it's hepatotoxic. So now these are specific to the immune response. So there's cyclosporin, which the main thing to know is it inhibits interleukin-2, which is involved in T-cell activation, so there's less T-cells activated. Note, anything that's stopping T-cells will not be very useful in something like a hypersensitivity, like an allergic reaction, because those are usually antibodies and stuff, not T-cells. And it's nephrotoxic and can lead to a bunch of other things, but note that it's not hepatotoxic. And then infliximab and rituximab, they're monoclonal antibodies. MAB stands for monoclonal antibodies, which basically means that we've synthesized a copy or billions of copies of one antibody, which does something that we want. So infliximab stops tumor necrosis factor alpha, so it stops this inflammation, and rituximab stops, it binds to CD20. That's less important. What's more important is it shows the natural killer cells that, like, we want these B cells to be dead, so it will stop the B cells. And yeah, so a monoclonal antibody is we found a certain antibody latches onto a target we want, and we just make a million of them. Just a few other drugs. There's sulfasalazine. Again, these drugs are less important. I didn't really see them much before I made this slideshow. And it lowers cytokines. Anakinra, never heard of it before, but it's an interleukin-1 receptor antagonist. Yeah, I have no idea. The amazing things you find on ePharmacology. Hydroxychloroquine, it blocks the toll-like receptors on some dendritic cells, so there's less activation. And again, when it comes to rheumatoid arthritis or any DMARDs, we're just trying to stop the immune system. Gout, there's 3 drugs, and they do these 3 things. And, the list only has 2, but we were taught 3 quite properly. There's allopurinol, a competitive inhibitor of xanthine oxidase. Again, one of those enzymes that for some reason I like to ask questions about. This is involved in conversion of xanthine to urate. So obviously if there's less urate or uric acid, there's less gout. I should point out for anyone who doesn't know what gout is, it's uric acid secretion or depositions in the joints, and then the immune system attacks it, and it's very painful. Probenecid, so that inhibits reabsorption of uric acid in the kidneys, so you're just getting rid of what you've already made. And since there's more uric acid in the kidneys, it can lead to uric acid kidney stones, which are painful. Colchicine, now this stops neutrophils from moving to the joints and degranulating, and it's used in acute situations. So what happens is if you do anything to change uric acid levels, it's very painful. If you increase or decrease uric acid levels. So whenever a doctor starts a treatment for someone, they give them colchicine, because otherwise what happens is people start the drug, their pain gets way worse, and they stop the drug. But they don't realize that they're ruining their joints. A picture version of this. Okay, so which of the following is the primary treatment of rheumatoid arthritis? My favorite drug, methotrexate. Rheumatologists are really, really into it, as I've said. That is not meant to be there. Marcus has been recently diagnosed with rheumatoid arthritis. He's adamant that he doesn't want to take any meds that stop cell replication because, I don't know, he's heard that it's really bad because cancer is bad. Which of the following would he willingly take to treat his rheumatoid arthritis? So there's methotrexate, allopurinol, azathioprine, infliximab, and leflunomide, and the answer is infliximab. Allopurinol also doesn't affect cell replication, but it doesn't treat rheumatoid arthritis either. And the other three have to do with replication. Ruby presented to the GP with elbow pain. Upon examination, her GP notes gouty tophi on the affected limb. She prescribes Ruby allopurinol in the long term. What short-term intervention may the GP also prescribe? And I went on a bit of a rant. The answer is colchicine. And I've sort of skipped it because I spoke about it. 65-year-old male with a history of liver cirrhosis has just been diagnosed with rheumatoid arthritis. Which of the following drugs would you prescribe and why? So would you give leflunomide because it doesn't lead to hepatotoxicity, leflunomide, but because it's renally excreted, so it doesn't bother the liver as much, azathioprine because it only has to do with lymphocytes, cyclosporin because it's not hepatotoxic, or methotrexate because the main side effects are GIT and hair. And the answer is cyclosporin. This is basically the only sort of cancer-style drug that we use that is not hepatotoxic. The rest will damage the liver. Okay. Pain management. So we'll be looking at NSAIDs, SAIDs, paracetamol, opioids, and local anesthetics. So pain is transmitted via afferent, meaning it goes back to the body, nociceptive, meaning pain neurons. So there's two main types. There's A delta, which is first and fast pain, and that's like, when you touch something hot. And then there's C fiber, which is slow pain, and that's more of an ache a lot of the time. So now iconosoids, they're substances that potentiate pain, so they make it worse. They actually don't have much to do with the pain itself. They just make us feel it more. And this includes leukotrienes and prostaglandins. So this occurs through prostaglandins because they open sodium channels, and so the nerves are sort of closer to being depolarized. And so therefore it takes less to depolarize the nerves and send pain to the brain. Now, cyclooxygenase, or COX enzyme, is necessary for prostaglandin production. So NSAIDs, our whole goal is to stop these enzymes. But note that only COX-2 is pro-inflammatory. The only reason we don't use selective COX-2 inhibitors is because they were leading to heart failure and stroke. But really COX-2 is the goal. This is an image of what I'm sort of about to explain, so I'll refer back to it soon. So the core NSAIDs, so we have ibuprofen, which is non-selective, and at low doses it has antiplatelet effects. So it stops clots. It can lead to sodium retention, gastrointestinal disturbance, and stomach ulcers. And it's sort of the main drug that people give for mild to moderate inflammation and fever. The only people who don't like it are nephrologists, because I think it's not good for the kidneys in the long term. So aspirin irreversibly inhibits COX-1 and modifies COX-2. Biggest thing to remember is it can lead to salicylism in overdose, which I will look at. And at high doses, it goes to zero order kinetics. So if you're giving someone high dose aspirin, got to be quite careful about how you do it because the body's not that good at getting rid of it. Meloxicam is mainly selective for COX-2, but we've spoken about that's not so good. Diclofenac is a non-selective COX inhibitor, and it's like Voltaren. So it's a topical cream a lot of the time. And I'm sure anyone here who does a lot of sports knows a bit about Voltaren. So salicylism is an acute medical emergency, and it presents with tinnitus, which is the ringing of the ears, and deafness, renal failure, and interstitial nephritis, so that's inflammation of the kidneys. and you give activated charcoal to stop further absorption, and alkaline diuresis will balance the acid-base imbalance, because remember that aspirin is metabolized to salicylic acid. So obviously you don't want to have too much acid in you, that is bad. And dialysis may be necessary if the kidney damage is extensive enough, and obviously if the kidneys are dying, it can lead to death. Paracetamol is a little bit separate because it's not anti-inflammatory. We don't really know what it does. We know it works in the central nervous system. We think there's some sort of COX-3 enzyme that we don't understand. We really don't know, which is funny because everyone takes so much paracetamol. But the adverse effect, the main one, is that its metabolite from liver processing is extremely hepatotoxic, to the point that 35% of cases of severe liver failure are caused by paracetamol poisoning. So while the side effects of paracetamol are less, you don't have that stomach problems, you don't have any of these weird anti-inflammatory problems. If you take an overdose, it's like a big deal. As opposed to, for example, ibuprofen, an overdose will likely lead to gastrointestinal issues like stomach ulcers, but not death. Steroids. So they are synthesized in the adrenal cortex. So they come from cholesterol precursors. They can be divided into glucocorticoids and mineralocorticoids. You only really need to think about glucocorticoids this year, and they regulate sugars. But at a high dose, they have a strong anti-inflammatory effect through this double action of inhibiting phospholipase A2, which I will go to the picture again, and it inhibits this thing, which would otherwise promote COX-2 action. So it's also indirectly stopping COX-2 from working very hard. And you give it in adrenal insufficiency, because the adrenal gland is what makes the steroid, and you also give it in inflammation and allergies. So the core glucocorticoids are prednisolone, which is the most common one you will come across. Side effects to be aware of is it can raise blood sugar in diabetics. And also, these are special side effects. Then at the bottom, I've got the general ones for all glucocorticoids. Dexamethasone is very potent, and it's used often in testing. And then fluticasone is inhaled. It's used in asthma. So anyone who has severe asthma and is taking steroids most likely has fluticasone. And because it's inhaled, and most of it's really just sticking to the lungs, there's less of this systemic side effect. So an adverse effect can be Cushing's syndrome, which basically comes from a negative feedback loop. So when the body has endogenous corticosteroids or glucocorticoids, it sends back to the brain saying, we don't need any more. So the brain doesn't send the signal to make more. If you're giving exogenous steroids, the brain's telling the body to make less and less, because the brain goes, oh, we have so much steroid. But when that happens, the body sort of becomes deconditioned and it's no longer able to make steroid like it did. So, and if there's no steroid, we can end up with growth suppression. Oh no, sorry, this is in long-term use. There's growth suppression, osteoporosis, hypertension, and increased risk of infection and central adiposity. So that's what someone with Cushing's syndrome looks like. We speak a lot about the moon phase and that central adiposity. Those two things are often going to be in the question stem if they've got Cushing's, and also hyperglycemia and high blood pressure. Okay, so opioids. We have 3 opioid receptors, but we only really care about the mu receptors, but there's also these other ones. And we want agonists because opioid receptors stop pain. So there's like a bunch of things we do, like maybe be aware of it, maybe not the biggest deal, but they open calcium channels on the first order neuron, so they can't release the neurotransmitter. So they keep it open because calcium is needed to release, but you need to do that whole resetting thing like everything else. It opens the potassium channels on the second order neurons, so it's hyperpolarized because all the potassium leaves, it becomes super duper negative, and then it's much harder to reach that point where it then shoots up. And this works together, and it inhibits the release of, so these work together to inhibit the release of acetylcholine, norepinephrine, 5-HT, glutamate, substance B, and these are all things that can increase sensations of pain. I should mention that 5-HT is serotonin because I found that out this week and it blew my mind. The side effects are respiratory depression, so that's the most common cause of death in overdose. So that means you breathe less and you breathe more shallow. Depression of cough reflex, sedation is a big one, nausea, vomiting, the gastrointestinal system slows, and then addiction is the other really important one. So all the drugs do the same thing, so we just need to speak about special features. Fentanyl is used in short term. It's like crazy strong and leads to super high dependencies. So that's fentanyl. Codeine and morphine. So codeine is metabolized into morphine, but it's just way less potent, which is why people will take codeine tablets, and the morphine's only really given in hospital. And we don't use in breastfeeding women because it can basically enter breast milk, and that's not good. You do not want to be getting the baby high. Tramadol is a weak opioid agonist, and it also works as a serotonin norepinephrine reuptake inhibitor, which is relevant if a patient's taking antidepressants, because a lot of those will work by impacting serotonin norepinephrine levels. And if you have two drugs doing the same things, it's not always the best. Now, this has less dependence and less respiratory depression, so it's a reason why you might use it. Loperamide is not absorbed orally, so it only sits in the gut. If anyone's ever heard of GastroStop, which is a drug here in Australia, that's just loperamide. And it's very strong, so it can actually lead to constipation as the side thing, even if you take it for the right reason. I don't know why you would take it for the wrong reason. I'm sorry. Naloxone is a mu receptor antagonist, and it's used in overdose. A lot of ambulances and hospitals, they all have it on hand, and because it works really quickly, really useful. Addicts in therapy use it, so that even if their resolve breaks, even if they have some sort of relapse, it won't be as strong because their dependency won't really go up. Only thing is it can cause hyperalgesia, and it can lead to stronger withdrawal symptoms. And then there's dextromethorphan, which I've never seen before, but it stops coughs. And then methadone is a really interesting one. In Australia, I don't know what we do overseas, but people use it they use it for addicts to help them get over their addiction and get past it. So it's actually an opioid which is given to people with an opioid addiction because it has a longer half-life, and the withdrawal symptoms are less intense. It's sort of a lower high, and the high peters off more slowly, and it's really, really useful in helping people who are really struggling with addiction. This is a table version of how these things work and how strong they are. Kind of good to know how strong they are, and I don't think it's that hard to remember. Okay, local anesthetics, last type of drug we're looking at. So they block the sodium channels by binding to specific receptors on the inner portion of channels, so they need to be on the inside. And anything downstream will also be blocked because transmission travels up the nerve fibers. It's more effective on small diameter, unmyelinated nerve fibers, obviously because it's easier to get through and there's less to deal with. That's why pressure tends to remain, whereas pain goes, because pain is smaller unmyelinated nerve fibers, whereas pressure comes from myelinated and large diameter fibers. Anyone who's had local anesthetic probably understands that, as in has seen it before. And then there's two kinds of local anesthetics. There's esters and amides. So esters are broken down in the liver, so they sit longer in the bloodstream doing their thing, so they have a longer half-life. Amides are broken down in the plasma, they have a shorter half-life. And the way to know which drug is which is if there's an I early in the word, it's an amide. So there's bupivacaine, which is an amide, so it can lead to respiratory depression, heart depression, vasodilation, and it's not so easily broken down because it's an amide. Lignocaine, same thing, it's an amide. It's used in epidurals and nerve blocks. Same thing as bupivacaine for the adverse side effects. And it's so it's also less easily broken down than esters. And then tetracaine or amethicane is also the same adverse effects, but it's more easily broken down. So it's shorter acting. So last sort of batch of questions. Paracetamol is best described as a steroid, an NSAID, an opioid, a simple analgesic, and it's a simple analgesic because we said it's specifically not an NSAID. NSAIDs act by inhibiting arachidonic acid, phospholipase A2, leukotrienes, and cyclooxygenase. The answer is the COX enzyme. Which of the following is not true regarding codeine? It is less potent than morphine. It is safe to use for breastfeeding mothers. It is a pro-drug, and it is less addictive than morphine. And the answer is it is safe to use because it is not safe to use for breastfeeding mothers. And pro-drug just means that it's not active in its sort of administered form. The body has to do something to it first, and you'd be surprised so many drugs are pro-drugs. Which of the following is and are distinguishing features of paracetamols compared to NSAIDs? So no antipyretic action, which means lowering fever, no anti-inflammatory action, no gastric adverse effects, and some mixes of them. And the answer is B and C, because it does bring down fever, but it doesn't stop inflammation, and it doesn't have gastric adverse effects. Opioids cause analgesia by opening K+ channels, closing calcium channels, opening calcium channels in the posterior horn of the spinal cord, and inhibiting the effects of GABA. And it does all of these things. Really not that important, but just some more details on opioids to sort of put into a question. I would just tell you my general rule for all of the above questions, because no one's ever going to know every detail on every drug, is if you can find two things you know for a fact are true, and you're not 100% sure about the other two, it's probably all of the above. Okay, a 60-year-old man with a history of methamphetamine use and moderate COPD presents an emergency with a broken femur after an automobile accident. He complains of severe pain. What are the considerations of the case? So the patient suffers from addiction, so that's part of a history. He already experiences respiratory problems, and obviously he needs pain relief. I meant to say pronto, but it says pronton. I fixed it in another slide. Okay, so what treatment would be suitable? So there's NSAIDs, because there's less risk of dependency, steroids, because it will lower inflammation, so there's less pain, opioid, because it needs intense intervention, or a nerve block. And the answer is kind of C or D, because at the end of the day, we do worry about putting someone on something that leads to dependency, but if someone's in enough pain, it's way more important to get rid of their pain than, and you deal with the next problem as they arrive. So these are two really strong options of pain relief, and it will just really depend on how the patient's responding to them and exactly how bad the situation is. But those are the two you'd be looking at.
Someone just had a question. Could you possibly go back to the slide which talked about esters versus amides?
Sure.
I think the question they have is where they're broken down, whether so the suggestion being esters are broken down in the tissue versus amides broken down in the liver.
Should it be that?
I'm just having a look at Richard's slide, and I think that's
okay. So it's a mistake. Yeah. So I'll fix it all for the post slide. I apologize. Okay. Once aspirin has been fully absorbed, what is the treatment for salicylism? So there's activated charcoal, naloxone, alkaline diuresis, all of the above, or just A and C. And the answer is just alkaline diuresis, because activated charcoal is to stop absorption. If it's absorbed, we don't really, it's sort of useless. Which of the following opioids may be used in treating diarrhea due to poor absorption in the gastrointestinal tract? So there's codeine, morphine, tramadol, loperamide, and colchicine. And no, it's definitely loperamide. I've just folded the wrong one. An elderly woman presents with pain in the knees and elbows. Blood tests show high levels of uric acid in the plasma consistent with gout. Her GP prescribes allopurinol to reduce uric acid synthesis. She includes another drug to be given, and she gave colchicine. What aspect of aspirin makes it the NSAID of choice in heart failure and atrial fibrillation? So aspirin inhibits both COX-1 and COX-2. It irreversibly binds to its binding site. It's a weak acid. It's excreted by the kidneys, or it's got a strong antithrombotic activity. The answer is E. We're basically trying to stop clots. And that's it.
Oh, okay. Good time. Thank you so much, Eitan.
No worries, and I will fix whatever. There were a few things
that's perfectly fine. So guys, if you have any questions, the slides will go up. I'll put up a post with the slides as well as with the YouTube link. So that should cover like a few questions we've gone through and a few changes we've made as well.
Yeah. And I'll when I edit the slides, I'll include my details. If anyone has any questions or any study tips or anything like that, feel free to get in touch.
No, absolutely. And we'll be having two more revision lectures next week, which would be on cardiophysiology and cardiopharmacology. So stay tuned for that. And also, I found this really wonderful resource I would want to show you guys because I feel it could be potentially quite useful for a lot of people. So this is something I found out by doing a bit of digging on the Muse academic drive. So this is pretty much like this huge summary doc which covers pretty much everything you would be expected to know from the entire semester across all 4 themes. And I'm being a bit mindful that this is from previous years, so I went through this. A lot of the things aren't as relevant, and that's primarily because a lot of them haven't been covered for your year. But most of the stuff covered in your year should be here. So if you guys want to have a look or just use this as a revision doc, that should be, I think, quite appropriate. So if you guys want to know more about that, feel free to get in touch with me. But yeah, again, thank you guys so much for coming in, and I'll see you guys next time.
Do you know what happened, by the way, with the